So I have the very hard task to keep you awake by the end of the hora de la siesta. Now, I was thinking of putting some pictures of the side effects of sildenafil just to wake you up, but for the sake of decency, I won't do that. Anyway, I'll talk about shortly about the medical therapy of heart failure, a small short case presentation, about the classification, definition of pulmonary hypertension, background for PDE5 inhibition, experience with PDE5 inhibition heart failure in some papers, and what about the tolerance and side effects of PDE5 inhibition, and then I can conclude. So we've gone a long way in treating patients with heart failure, first in the kind of renal syndrome model, not syndrome model, which related the heart failure to excessive salt and water retention caused by abnormalities of the renal blood flow when we treated those patients with diuretics. Afterwards, we went on to the cardiocirculatory hemodynamic model. We thought that it was reduced cardiac output and excessive peripheral vascular vasoconstriction. We treated those patients with anotropes and IV vasodilators. And then, just from the mid-80s, we went to the neurohormonal model with renin-angiotensin system and sympathetic system activation, and then we treated those patients with ACE inhibitors from the beginning of mid-80s. Then we went to treat those patients with beta blockers in the mid-90s, and just by the beginning of this century, treating those patients with mineralocorticoid antagonist, we did manage improved prognosis, and we were able to delay the disease progression, and obviously we did not stop it. And now we see, after 20 years of treating those patients, we see the results of that therapy. And for the last 10 years, although I like the desert very much, this comes to show that we, in the field of new medications for heart failure, we don't have much. Now, what happens to those patients? As I said, there is gradual progression of the disease with gradual elevation of pulmonary pressures, with slowly worsening of the right ventricular function, with combination of low perfusion and congestion of the organs, low cardiac output, low blood pressure. Patients become intolerant to drugs, malabsorption occurs with cardiac cachexia, multi-organ failure, and then there's extreme agonizing weakness that eventually takes those patients to death. Short case presentation. This was a patient that was referred to us from another hospital. He was first presented in 2007. At that time, he was 50 years old, had multiple risk factors of diabetes, hypertension, dyslipidemia. He smoked and he was obese. He had small myocardial infarction, inferior posterior, 205. That was treated with PCI to the marginal, to the first marginal. Although he did have 3-vessel disease, he had post-infarction angina and eventually went to bypass where they had one arterial graft with the proxial AD and then 4 venous grafts. He left the hospital eventually with mild left ventricular dysfunction, pulmonary artery pressure of 37 millimeters of mercury per artery pressure. During follow-up, the next year, he was doing quite well with global LV function within normal limits, posterior wall myocardial abnormality, wall motion abnormality, and right pulmonary artery pressure rose to 42. And he continued smoking, and by February of 2009, he had another non-ST elevation myocardial infarction, was hospitalized due to pulmonary congestion. They catheterized him. He had non-treatable coronary disease, moderate LV dysfunction, and pulmonary artery pressure that came up to 49. By February, he was deteriorating with moderate to severe LV dysfunction, still preserved RV function, and PA pressure of 56. By September 2009, he had severe dysfunction, EF of 30%. The RV was now hypokinetic. His PA pressure was 54, and he was a very low functional class. In 2010, he was recurrently hospitalized due to acutely compensated heart failure. His heart failure was worsening. And by February 2011, this year, he was referred to us for the first time. Until that time, we did not see him. And with severe left ventricular dysfunction, RV dysfunction, mild MR, moderate to severe TR, and PA pressure of 64, and he was short of breath at rest. In the hemodynamic study without the catheter in the left ventricle, he had a artery pressure of 19 millimeters of mercury. The PA systolic and diastolic were 85, 40, and 56 mean, wedge pressure of 36, cardiac output of 2.8 liters per minute, and PVI calculated of 7.1 Wood units. At this point, the patient was obviously non-eligible to heart transplantation, and we evaluated him and tried to see if we can insert a LVAD in him. but eventually did not survive and died. Classifying patients with pulmonary hypertension, we saw before all the talks concerning primary pulmonary hypertension due to congenital heart disease, veno-occlusive disease, pulmonary disease, so pulmonary disease here, thromboembolic pulmonary hypertension, and so forth. And actually, this class 2 of pulmonary hypertension that we just published in JCC in 2009, due to left heart disease, systolic dysfunction, diastolic dysfunction, or valvular disease, actually this is the largest group. The vast majority of patients with pulmonary hypertension hanging around there are patients with pulmonary hypertension due to left heart disease. And it is present in more than 70% of the patients with advanced heart failure. The increase in PVR and the poor RV function are, of course, very, very bad prognostic signs. With reduced functional capacity, quality of life is very much reduced, and the prognosis is poor, of course. The hemodynamic definition of post-capillary pulmonary hypertension include, as before, resting mean pulmonary pressure of above 25, but then the wedge pressure has to be above 15. Concerning what was spoken before, we have a big problem with the remodeling of the pulmonary artery endothelium, and this is the main patho-physiologic mechanism in pulmonary hypertension secondary to LV dysfunction. And we have impaired production of vasodilators such as NO and prostacyclin, and overexpression of vasoconstrictors such as endothelin 1. This results in vasoconstriction, local thrombi, and arterial remodeling. Now, talking about how to treat that, so there is no specific therapy for pulmonary hypertension due to LV dysfunction, and the argument is that you should treat the LV dysfunction, and by that you would lower the pulmonary hypertension. Eventually, we do see that in patients where we insert an LVAD to those with excessive pulmonary hypertension, you put an LVAD in, and hopefully by 3 to 6 months, the pulmonary hypertension lowers down. There is a large group of patients that, despite that, the pulmonary hypertension does not go down, arguing that maybe the arterial modeling has not been, you could not regress it, and eventually those patients stay with the elevated pulmonary pressures, and they cannot be candidates for heart transplant, and they stay on the LVAD as a destination therapy. Now, those were three drugs that we can use. We could either use to antagonize the endothelin pathway, the endothelin receptor antagonist. You could either use prostacyclin that we heard before, or could use the nitric oxide pathway with PDE5 inhibition. And we know from the study of Kolowski and colleagues that was published 3 years ago using bosentan, a very well done study that demonstrated that when you give long-term bosentan to patients with pulmonary hypertension secondary to heart failure, you see much more adverse events and no benefit at all. So we don't use bosentan in patients with heart failure and pulmonary hypertension. There are not many control studies, not at all actually, using prostacyclin in patients with heart failure and pulmonary hypertension. So we are left with the PDE5 inhibition. Now, the therapeutic goal in advanced heart failure is to improve overall cardiac function, and by that to reduce the PVR, which is calculated. I won't go back into that. Then reduction of the PVR leads to improved RV function, LV function, cardiac output, and exercise capacity. In patients with advanced heart failure, NO-mediated vasodilatation is decreased in all vascular beds, in the skeletal muscle vascular bed, as well as in the coronary and the pulmonary vasculature. Now, experimental studies with PDE5 on the heart showed evidence that PDE5 is expressed in isolated myocytes. PDE5 inhibition inhibits the acute beta-adrenergic stimulation. PDE5 is upregulated in pulmonary hypertension, in RV hypertrophy, and in advanced heart failure. And the PDE5 inhibition improves contractility in the hypertrophied right ventricle. Now, this is the molecule of the sildenafil. And concerning studies that were done with the sildenafil, one of the first studies was published in 2007 by Marco Guazzi from Milano, and he used long-term sildenafil in treating patients with heart failure. He took stable heart failure patients, assigned them randomly to either placebo or sildenafil, 23 patients in each group. He gave them 50 milligrams twice a day in addition to the current therapy they were taking, and followed them up for 6 months. He saw statistically significant reduction in the systolic PA pressure from 33.7 to 25 millimeters of mercury, and treating those patients after 3 months and going on for 6 months, this reduction was sustained. VO max increased from 14.5 to 18.5, showing that this was not the most severe group of patients. And then he concluded that chronic sildenafil seems to be a remedy based on heart failure patho-physiology with no side effects. Another study, sort of a crazy study by Gregory Lewis, and in this study the patients would sit on the bike during the cardiopulmonary exercise test. They had the arterial line in the radial, they had swan guns in the jugular, and they were examined that way 2 times at least. So there were 34 patients with systematic heart failure and pulmonary hypertension. They were randomized to 12 weeks of therapy with sildenafil from 25 to 75 milligrams 3 times a day. A nice dose. And they were with placebo. And the patients underwent cardiopulmonary exercise test before and after the treatment, as I said. And then the peak VO2 changed from baseline in the sildenafil group by 1.8. And in the placebo group, it did not change at all. And the Minnesota Living with Heart Failure questionnaire was improved also in those patients. And he concluded that phosphodiesterase 5 inhibition improves exercise capacity and quality of life in patients with systolic heart failure and pulmonary hypertension. You can see here the peak VO2 that did not change in the placebo group and did change in the sildenafil group. And the cardiac output also did not change in the placebo group and did change in the sildenafil treated group. Here you can see a 6-minute walk test, showing the improved functional capacity of the patients, and the Minnesota Living Heart Failure questionnaire decreased, as shown, improvement. With the Minnesota, the lowest grade is the better quality of life. Another study, the same Marco Guazzi, just published this year, showed that pulmonary hypertension in heart failure with preserved ejection fraction treated those patients with sildenafil. Took 44 patients with heart failure and preserved ejection fraction and PA pressure above 40, and randomly assigned them to either placebo or sildenafil 50 milligrams 3 times a day. And here also he found improvement in the pulmonary artery pressure, in the RV function, improvement in left ventricular function with improved diastolic function parameters, and those results were similar after a year of therapy. You can see here that with the placebo, pulmonary arterial resistance PVR does not improve after 6 months, and maybe even worsen later on. And with the sildenafil, the pulmonary PVR decreased, and the decrease was sustained for the next year. What about side effects? So sildenafil 50 milligrams 3 times a day was not shown to increase the norepinephrine plasma levels at rest or in exercise. You have to be cautious because there might be some interaction between the PDE5 inhibition and the level of cyclic AMP in myocytes. I know that from those treated with milrinone that this can increase the rate of sudden death. In most studies where patients received 50 milligrams 3 times per day for 6 months, no major adverse events were observed. There were no visual disturbances. Renal and hepatic function remained unchanged. There was no initial dose hypotension or headache or any sexual disturbances leading to discontinuation. We did have small amount of patients, 2 and 3 patients, that responded to therapy with sildenafil with dyspnea. So we were concerned about that, and from now on, that might be because of flooding the left side because of reduction of the pulmonary pressures. And there is some increased flushing in some patients. This goes out after quite a short term of therapy. And this did cause a problem in a 17-year-old boy that had pulmonary hypertension, underwent heart transplantation, and after the transplant we still gave him the sildenafil 20 milligrams 3 times a day, and he came the other day and said, "I cannot have that anymore, please take this drug away from me." A conclusion, PDE5 inhibition with sildenafil does improve exercise capacity and quality of life in patients with pulmonary hypertension secondary to systolic LV function and secondary also to diastolic LV function. Chronic sildenafil seems to be devoid of significant adverse effects, and it improves the exercise capacity for a long time. Now this is the bridge of the Yalkon River, which before it was reconstructed, so we did need something to bridge those patients to improve. This is how it looks now, and this might be like sunrise, but actually, so there's a new drug that is sunrise, but Ofer, can you tell what's over here? So this is Acre looking at Haifa, and this is actually the sunset. Anyway, thank you for your attention.